Hey there, good evening. Welcome back to I Care for Your Brain with neuropsychologist Dr. Karen Sullivan. That is me. I am here because I truly care for your brain. We started this about 5 years ago. July 24th will be our 5th year anniversary of offering free evidence-based brain health lectures to you, the brain health community, on Facebook. We are about 200 followers shy of meeting our 10,000 follower mark. So if you've liked the page before, or maybe if you haven't liked it or followed it, you could give us a follow and help us reach that goal. That's going to be very, very exciting. This week's topic is gabapentin. You might also know it by the name Neurontin. I picked this topic because this medication has been on my radar for maybe about a year or so. I started to have patients who were complaining to me that at higher doses, they were having some cognitive symptoms. So what I mean by that is they were concerned that they were feeling foggy, that they couldn't pay attention, and some even saying that they thought their memory was being impaired. So I started looking into it in depth, and by the time I'm into doing a research project, by at least a couple hours, I then think, you know what, I should put this into a PowerPoint and share it with our people on Facebook. So tonight you're going to learn a lot of what I learned about gabapentin. I'll tell you in advance, there's not a lot of very strict, hard and fast rules in my recommendations. We're still learning a lot. But I certainly think there are things that you should know to be a more empowered and educated consumer of this medication. So it was actually discovered in Japan in the 1970s, and the way they first considered this compound was as something that would help people have relaxation of their muscles and would prevent spasms. It then gets bought by a major American pharmaceutical company, and in 1993, it first gets FDA approved to help with partial seizure control. So there are many different subtypes of epilepsy and seizures, and so partial seizures are one type. And then in 2003, it gets its second FDA approval for nerve pain. And so now generally it's considered to be an anticonvulsant and something to help calm nerve pain specifically. The doses can range quite a bit, all the way from 100 milligrams a day, all the way up to 3,600 and more per day. One of the things I found to be fascinating about gabapentin is they actually don't have a super clear idea of how it works, and they actually think it works really differently in different people. But the mechanism of action, so to speak, how does it work, is typically thought to be related to something called GABA, a chemical in the brain called GABA. So it increases GABA, which has an inhibitory effect, which helps cells fire less, kind of calms brain cells down. But it also reduces, so it increases GABA, reduces several other neurotransmitters, specifically calcium in the brain and something called substance P. So what these things do is they reduce the excitability of a brain cell, of a neuron. When brain cells are firing too much, this is when we can get seizures, or this also contributes to the experience of pain. So it is reducing the firing of certain brain cells in the brain. So even though you may still have, an injury to your hand, the pain is perceived in your brain, and we are able to calm specific nerves in the brain that will help reduce the experience of pain. You can kind of think of it, it's like a calming drug for brain cells. It takes an average dose of 300 milligrams about 2 to 3 hours to reach its peak effectiveness in a person, and it stays in your system for between 5 and 7 hours. The most common side effects are fatigue, unsteadiness, and dizziness, which is something that really was on my mind when I figured out that it is being recommended for people with tremor disorders, movement disorders. I kind of thought, with that being some of the highest side effects, are we helping more than we're hurting? So it is wildly popular. This is why it was on my radar screen. The prescribing in the US of gabapentin from 2012 to 2016 shot up by 64%. That is really, really high. As of 2020, gabapentin was the 6th most commonly prescribed medication in the US and the UK, with almost 400 million prescriptions from 2004 to 2018. That is really high. Here's where things got really interesting in my research. Over 95% of the prescriptions for gabapentin today are considered to be off-label usage, meaning it's not for seizures and it's not for pain control. The main reason for this is really due to the medical community's resistance to want to prescribe two other classes of medications. Think about it. In the last few years, people have gotten very aware of the dangers of opioids, so the OxyContins of the world, but also benzodiazepines, things like Xanax and Klonopin. Doctors don't want to overprescribe those. There are not only ethical considerations and issues of it really not being great for your patient, very easily addicting drugs, but also there's a lot of liability. There's a lot of monitoring that happens around doctors prescribing those two classes of medications, an opioid or a benzo. So here comes gabapentin, kind of considered to be, wow, there's this new safe medication. But that is really being questioned. Not that it's been proven that it's unsafe by any means, but more and more doctors are saying, how can this one drug be a balm for so many ailments? How is it that there are so many conditions that would benefit from this one compound? So let me just go through and tell you, this is like the top 15 reasons people get prescribed gabapentin. So first we have anxiety, social anxiety in particular, alcohol withdrawal, hot flashes, itchy skin, attention deficit disorder, migraines, bipolar disorder, post-traumatic stress disorder, obsessive compulsive disorder, low back pain, sciatica, insomnia, irritable bowel syndrome, overactive bladder, restless leg syndrome, hiccups, and chronic cough. How wildly different are all of these different things? So there is very little evidence to support that it is effective in any of those populations. And if it was, we would see FDA approval with those things because they would have the standard of evidence, the volume of evidence to go in and get it FDA approved, which is what a pharmaceutical company would love to do. So this is kind of the concerning, like, you start to feel like, okay, what has been behind the amazing amount of overprescribing? And yes, maybe it is all just that doctors needed an alternative. But there's also some really interesting research that maybe what gabapentin does really is has ties to all these different disorders because of its calming properties, because of its ability to reduce hyperexcitability in brain cells. When you are calming parts of the nervous system, we can't select for it to specifically treat hiccups. We can't select for it to specifically reduce nerve pain. What you're going to get is a general calming of the nervous system. And the idea is that maybe hyperexcitability of the nervous system is a common thread amongst all of those other disorders. So there's a really interesting debate going on in the literature right now that's kind of like, wow, is this kind of a wonder drug? Or is it really just that it's been overprescribed and it can't possibly be something that is going to soothe and help manage all these wildly different disorders? So that's a question that's not been answered yet, but it's definitely in the literature. Quite a few of you wrote me questions on my Facebook page asking about this drug, which I absolutely love. And at the end, I'm going to try to get to a good number of those. But one of the things I really wasn't aware of until you all informed me, which I love, is how often it's used in essential tremor. And I know I have a lot of my ET people out there. And so I wanted to tell you about a 2020 study that is kind of like as good as it gets when it comes to gabapentin and essential tremor. So basically this is a double-blind, placebo-controlled study, crossover design. It's like ideal, okay? So what they did is they had 25 people, which not great, had them at two different doses, 1,800 a day, milligrams, and 3,600 a day. They also had them stay on their other ET medicine. So these are people who could have also been taking clonazepam. These are also people who could have been taking propranolol. So it is a little dirty there. And only 20% of the people, 20 of the 25 people in the study continued it. So we have data on 20. So what they found is that their observed tremor scores decreased when they were taking the gabapentin. They got better at pouring water, and their activities of daily living scores significantly improved, okay? But what didn't get better was their spirograph. So when they drew the spiral, how shaky it was. They didn't get better at walking anymore. And so what they basically said was gabapentin may be effective in some people who have ET. So not very satisfying, not very insightful. We certainly need higher numbers in future studies. But I think one thing I've learned from doing this research is how individual responses are to gabapentin. And I'm going to encourage you, as always, to be a really good communicator and advocate to your brain health provider, whether you have a good or bad experience with gabapentin, because it really depends on quite a few variables. So I grew to understand that the very thing that's good about gabapentin might be the thing that's problematic. So basically, this global effect on the central nervous system, as I was saying before, we can't pick and choose within the nervous system, the brain, what parts get calmed and what parts get excited, right? Excitable drugs would be something like a stimulant, like Ritalin, or some antidepressants, things like Wellbutrin or Effexor. These things we know in general in the whole central nervous system elevate, excite, activate. This is a compound that calms, inhibits, soothes, okay? So what's hard about that is you're going to have some cognitive consequences when that happens. So we know a lot about this from looking at pain medications in general, or really even anti-seizure medications in general, because at the end of the day, gabapentin is an anticonvulsant. That's really its primary property, prevents brain cells from tipping over into a seizure state. We want the positive properties of gabapentin, but we also know that when we inhibit brain cells too much, we can get slowed reaction time, slowed processing speed. We can have trouble multitasking, and we can have trouble with memory. And sure enough, those are the very things that when you find literature, scientific high-quality literature on gabapentin, what it's really saying is that there may be some effects, and they're more likely mild. So that sticks in my craw for two reasons. One is what might be mild in a scientific study might not be mild to you. Being absent-minded, being forgetful, having trouble multitasking, that could actually be catastrophic to you. So that gets a little weird. The other thing is that on Google, okay, I saw a ton of postings from people who take gabapentin who said it really hurt them cognitively. But when you go to the actual scientific literature, PubMed, Google Scholar, all of these different research journals that I search to get my information, it's really a different picture. So what that tells me is there's a lot of patient complaints and not so much verification of that in the scientific literature. Why that is, I'm not quite sure. But what I know about is gabapentin is always written about as though what's so good about it is it's better than what came before it. So in seizures, the first generation of seizure medications were really hard on people. People definitely had cognitive symptoms. They definitely struggled. They had seizure control, better seizure control, but they certainly struggled cognitively. So gabapentin is a second generation seizure medication, and it is very much more human friendly than the ones that came before it. Okay, so we think that it has at least 26 to 50% less side effects than something like Tegretol or carbamazepine, these old school seizure medications. But that still doesn't mean that it's cognitive risk-free now. So that's kind of what I kept coming up against is, well, hey, it's better than what we had before. Okay, but that doesn't necessarily matter to the person who's taking it now. I also mentioned to you that gabapentin is FDA approved for nerve pain. So I wanted to look into that group. And that, once you start to look into chronic pain, folks, man, your populations just explode. So you've got all sorts of reasons people have nerve pain. So one of the things I looked into was people who have spinal cord injuries often have nerve pain because of the accident or the injury that caused the spinal cord injury. And what they said is that gabapentin did negatively affect cognitive function, but typically just within the first week. Okay, so that was interesting. So is it just something you need to get used to? It did look like it did a decent job with pain. So they reported a 13% decrease. And I know that might not sound like a lot, but pain is extremely complex and notoriously hard to control. Pain is a very subjective thing. It's very hard to communicate to a doctor how you're feeling when you're in pain. And I think that's part of the disconnect. Nobody knows until they walk a mile in our shoes what it feels like to be with our chronic pain. And so when doctors are prescribing, you kind of have a communication system that just isn't going to work because you're relying on human language, right? So many times people who take gabapentin are also taking things like tramadol, things like oxycodone, even morphine. And this is really a problem when you're actually trying to understand gabapentin in isolation. Many of the research studies I looked at always had people taking other medications, so that complicates it quite a bit. It seemed that nerve pain patients reported drowsiness as a very common side effect, and it was much more typical once you reach 2,400 milligrams, for whatever that's worth. The kidneys do almost all the excreting of gabapentin, so this raises my concerns about folks over the age of 65 who are at much more higher risk for things like kidney function issues. And in general, their brains, the quality of their blood-brain barrier is less as we get older. That's kind of the wear and tear of the human brain over time. So we want to be especially careful of our older folks when they're taking gabapentin. We also, for all our motivation to get away from opioids, what I'm definitely seeing in this research I did was that more and more we're understanding that gabapentin can be misused and abused. This happens in about 15% of people. Most often, these folks have a past history of substance use or are also using opioids as they're using the gabapentin. So this became a concern to law enforcement because actually as they were going through autopsies, more and more in toxicology reports, they were seeing gabapentin was listed as one of the things that went along with the accidental overdose. There's a clear relationship between inpatient stays for people, drug-related stays, emergency room use, and increased levels of gabapentin. So the higher dose you take, the more likely you are when combined with other drugs that depress your breathing to have an accidental overdose. And I think that that's really important. In quite a few guidelines, they suggest being very cautious, if at all, ever combining opioids and gabapentin, so that's important. Nowadays, the FDA has required manufacturers to put new warnings on gabapentin, including that it can cause respiratory distress. I'm going to talk about Lyrica in a second, which is kind of the sister drug of gabapentin. It's now considered a Schedule 5 controlled substance in the US. And gabapentin and pregabalin or Lyrica have been reclassified as Class C drugs in the UK as of 2019, following an increase in the use of death and overuse reports. So what is pregabalin? We call it Lyrica here in the US. There is a little bit of a difference between the two. Lyrica is absorbed much quicker and starts working a lot faster. It reaches peak concentrations within an hour, whereas I said before, gabapentin is like 3 to 4 hours. And there's some evidence that Lyrica might be a little bit more addictive because of these properties. The big difference in terms of abuse is that about 15% of people using Lyrica report euphoria. So it's a drug that comes on fast, it leaves relatively fast, and some people are getting high from it. So that's the definition of something that's going to be addictive. Both Lyrica and gabapentin have withdrawal symptoms if you go off of them too quick. More memory symptoms are reported in the literature with Lyrica, with pregabalin, okay? So there's been reports of issues with memory for both verbal and visual information. So things you've seen and for things that people have told you. But the Lyrica cognitive issues are reported to be temporary under titration. So as we go up, that's when we seem to see the issue when we're increasing doses, okay? And the really bad problems with Lyrica also come along with the opioid co-combining. So if you're taking it on your own, you have less to worry about than if you're taking it together. So again, This is a complicated question. It's not as easy as, well, I'm going to tell you don't take gabapentin, or hey, have a free-for-all. You have to remember the medical conditions we're wanting to treat with these drugs also have cognitive symptoms. So chronic pain, in addition to making you feel awful, provides a very significant internal distraction that can divide our attention. And as human beings, we are no good at doing two things at one time. We like to think we are, but both things suffer. I also told you before, when you inhibit the brain cells in the central nervous system, things slow down. And this can reduce processing speed to the point where you can't remember because you weren't fully present when something was said. And this can happen just with pain. So we want to remember, sometimes we are choosing between the lesser of two evils. This is why we need skilled doctors to work as our partners, because it's sometimes not a black or white decision. It can be very, very gray, okay? So we want to be cautious. We want to be good communicators. I want you to talk to your doctors if you feel like you're experiencing anything out of the ordinary with this drug. Do not abruptly stop. If you are taking an opioid, you need to be extra careful. If you're over the age of 65, I want you to be extra careful. I want you to remember that this is all running through the kidneys, so you want to make sure hydration is at the top of your priority list if you're taking these drugs for any reason at all. What I'm going to do right now is go through some specific questions that you asked me. I can't get to them all, obviously, and if I don't answer your question, please don't think it wasn't a good question. It either means I just can only do so many. I didn't find a lot about it when I went doing my research. I got a couple questions about weight gain. This is a thing with gabapentin. The research says it happens at the higher doses, but because this drug affects people in so many unique ways, it's actually kind of a hard question to answer. So there was one study in 1997 that looked at body weight in 44 patients who were treated with gabapentin over a year. And what they found, and these people were gabapentin over 3,000 milligrams a day, 10% of the people gained more than 10% of their baseline body weight, 15% gained 5 to 10% of baseline body weight, 16% had no change, and 3% lost 5 to 10% of their body weight. So it's kind of a crapshoot, but I know from seeing patients, when they only add gabapentin, there's definitely a group that can gain weight and put on fluid in a pretty short amount of time. So that would be something that you should talk to with your doctor. The research suggests that between the second and third months of taking gabapentin is when the weight tends to come on, and they feel like it stabilizes after 6 to 9 months. And I'm not sure that would be tolerable to many of you. The next question is related to brain fog. Now, this is where I found a lot on Google, in chat rooms, in people's complaints, but not so much in the scientific literature. Clinically, this is a fascinating concept to me. Part of the problem with brain fog is we're not saying the same thing when I say it versus when you say it, right? We don't even have a definition for doctors to understand what this means. It can mean cognitive complaints. It can mean I can't cope with multiple inputs. It can mean my thinking is in mud. We need a better definition of what brain fog is. If you can articulate that and put that in a post here, that would be very helpful for me. I think of it sometimes like kind of thinking through cobwebs, that it is just a feeling of being fuzzy, of having a hard time focusing, and that is going to give you downstream cognitive effects like trouble with memory. You can't be foggy-headed and be focused. You can't be fuzzy in your thinking and be able to pay attention. And attention is the gateway, as you all know, if you follow me, to things like memory and decision making. You have to have good attention on the front end. The best I can say is listen to your body, listen to your brain, be neutral about what you expect when you take these drugs. We've talked about the placebo effect and the nocebo effect. If you expect negative things from a drug, you're scientifically increasing the chances that you're going to have a negative reaction. So try to be neutral and really work on being a good communicator. Someone asked me, is gabapentin the only drug to treat nerve pain? And the answer is no. Many anti-seizure medications are used to calm the nervous system. Some older antidepressants called tricyclic antidepressants opioids, but what they really prefer nowadays, where pain control is really going, is things like topical gels, things like cortisone shots, things like lidocaine gel patches that don't get into the central nervous system as much as a pill that you directly put into your body that can cross over into the brain. Someone also asked about it for stroke recovery and provided me with a wonderful link, which I so appreciated. So first thing I noticed about this link is it's a media site that was summarizing a scientific article that was in a very well-respected journal called Brain. I believe it's out of the UK. The first thing I wanted to do was go to the original source. At the very end of any media report, they should write, "This came from the journal Brain." It's the first thing I want you all to start getting in the habit of doing. Go to the original source. Media often spin to get the sensational headline, okay? When I went to go get the original article, after about 20 minutes of signing up for this and that, I basically realized I had hit a paywall, and if I wanted to read the study, I had to pay $52. Now, I don't have much to say about this because it's UK, I think, but this really bothers me. In America, with the vast majority of scientific studies are paid for by taxpayers, that we don't have access to scientific journal articles. That's a real disservice to the public. That's part of why I'm here, is we need more bridges from the world of academic science to the public. That's a real problem in public health in the United States, at least. But I did find the abstract. And so this is a very recent study from May 2022, and it was a mouse model, which is interesting and insightful, not quite done on humans, but I have to say I was impressed. It really gave some good arguments that gabapentin may increase neuroplasticity. What they found in the mouse was that they had more connections between brain cells when they were on the gabapentin. They had better integration from spinal cord circuits going up to the brain connected to forelimb muscles. And the most important thing is that they saw an improvement in function. You can tell me about an improvement at the structural level of the brain until you're blue in the face. I start to care when you tell me people or animals got better, because there's not a direct relationship in the brain between structure and function. What happens at the level of the brain doesn't necessarily translate over into people getting better or feeling any different. So what they found was that these little mice were able to recover the use of their little front paws better with gabapentin than without. So I think that is hopeful. I can't wait to read more about it. Another one of your questions was long-term use. So about 20% of people put on gabapentin never get off of it. It becomes a long-term thing. And again, this is because it's considered to be the lesser of two evils. But again, there's been a lot of studies that doctors need to monitor the use of gabapentin more. So for example, there's some work following older adults who are in the hospital, and they got put on gabapentin because, after a joint replacement or something. We need to follow these people very closely and make sure that they don't just stay on the medication because no one is providing oversight that they're still on it. This is why I recommend that at least once a year you do schedule a medication review with your primary care doctor, and you bring in everything, supplements, vitamins, prescriptions. Everything goes in front of them, and there should be a discussion. Is there still a benefit that exceeds the risk of taking this medication? That is very basic, good patient care that you can provide to yourself, okay? I hope that you found this discussion to be interesting. I certainly think it's worthy of your attention. Like I said before, if you would give us a follow here on our I Care for Your Brain page, we would be so grateful. I hope that you will share this far and wide on Facebook. I think there's a lot of folks out there who take this medication who have questions. And I hope this was just the beginning of a conversation with you and your medical provider to get the answers that you specifically need. So thank you all so much. Let me know what you think in the comments, and I'll see you sometime soon. Bye-bye.